Hello, everyone. My name is Simiran Choudhary, and I'm delighted to welcome you all to today's special session titled Think, Pink, Act Now, Screen, Fight, Win, organized by Voice of Healthcare and proudly supported by Cadila Oncology to mark the occasion of International Women's Day. As we celebrate the strength, resilience, and remarkable contribution of women across the globe, it is equally important to shed light on critical health challenges faced by women, one of them being cancer. The session aims to emphasize the importance of early detection, routine screening, timely treatment, and creating widespread awareness to improve cancer survival rates among women. And today we are truly honored to have with us Dr. Sushil Mandhaniya, medical oncologist, hemato oncologist, and BMT consultant at Madhaniya Cancer Hospital and Research Institute, Nagpur. A highly esteemed expert dedicated to cancer care, patient advocacy, and advancing treatment protocols with his exceptional expertise and unwavering commitment. Dr. Sushil has played a pivotal role in transforming cancer care by ensuring timely diagnosis, personalized treatment, and compassionate support, ultimately improving patient outcomes and quality of life. Welcome to our show, sir. It's a pleasure to have you with us.
Namaskar. Thank you. Thank you, Simran.
Thank you, sir. So, in today's session, we will discuss about early detection, breaking screening barriers, advancements in cancer care, and how women can take charge of their health. So, our goal is to inspire awareness, encourage regular checkups, and to reduce the fear of cancer. So, Dr. Sushil, without any delay, we would like to start our conversation by knowing why is early detection so critical in improving cancer survival rates? If you can share any real life case study where early diagnosis have made a significant difference, which you have witnessed
Yes,
in your
sure.
career span.
I will answer this question in two sessions, for two breaks. First thing is you have to understand what is the current situation of cancer care in India. So we have a population of 140 crores. As we say, nearly 30 to 35 lakhs cancer existing patients. Every year we are detecting more than 10 to 12 lakhs cancer patients, nearly 4 lakh cancer death. But having said this, this is just a part of the data because we have approximately 750 districts in India, but we have approximately only 50 cancer registries. So you can imagine this is just collecting the data of only 19% of the total population. So that means the original figures might be very, very high. First thing is this. Second thing is there is a peculiar thing which we see in India. We have a very advanced stages of disease, very late diagnosis, and that is the reason we have got more deaths as compared to the Western population. I will give an example here. When we talk about suppose breast cancer, we have approximately 2 lakh something patients diagnosed every year, but approximately more than 50% die within 1 year of the diagnosis. That means such a huge mortality, which is approximately 12%, 13% in Western countries. So why this is why we have got more deaths in India? The reason being we have got a very advanced cancer at the diagnosis, late diagnosis, lot of myths about the cancer, lot of myths about the cancer treatment, lot of the myths about the surgery, myths about chemotherapies, and there are a lot of people end up getting a lot of alternate medications before they turn up for the correct treatment. So there is one study which says there is approximately delay of 6 to 12 months, 6 to 12 weeks between the diagnosis and the start of the treatment, just because patients are into the some different form of therapy in the form of some alternate medication, and they end very important timing of the disease. So suppose we it's a breast lump which is just 1 centimeter, 2 centimeters, and which is a curable disease. Now, if there is a waste of the time in terms of some medications, in the terms of alternate medication, I will not name those medications, but generally we see those patients nearly 6 to 8 months coming to us with a huge masses in the breast, axillary node, supraclavicular node. So that means the stage one disease has completely turned up into stage four disease. In stage one disease, generally the cure rates are nearly 100%, but when we talk about stage four disease, we don't talk about cure. So the diagnosis and the early diagnosis, that is the main crux of the cancer treatment. Earlier the diagnosis, higher is the cure. The later is the diagnosis, lesser is the cure. So the stage of the disease is very important. And for that, the awareness is very important in terms of diagnosis, in terms of myths, solving the myths of the society, as well as there is a lot of awareness which is required by society as well as by the government. as well as for doctors also regarding the treatment, regarding the myths about the treatment. Because you will be surprised, we have a doctor's patient also who comes and tells us, he said, don't do biopsy because biopsy may lead to spread of the disease. So this is the level of ignorance in the doctor community also. So you can expect this कि in normal population it is quite reasonable कि ये रह सकता है, this is happening. So I will give one example here. When I was in Tata Hospital, Mumbai, actually I did my training from Tata Hospital and did my DM from AIMS New Delhi. So as of now, I had completed nearly 20 years in oncology practice. We had seen approximately, we had done more than 65,000 chemotherapies in my setup, and we do all types of chemotherapy, target therapy, immunotherapies. We had one patient who was from very, very rich family. I cannot name that. Very, very rich family. She came to us with a convulsions, जो झटके बोलते हैं ना, convulsions. So when we got her MRI done, it showed something in the brain, which was metastasis. That means spread. So when we evaluated her, it was a breast lump, which was there since last 2.5 years, and that had spread her to the brain. So they were the relatives and the daughters were shocked. How come it is so possible in our family, which are so educated? Our mother didn't tell us. So then they asked us whether is it possible we can have also this. Well, yes, definitely there is a possibility that she had 4 daughters. So when we screened all 4 daughters, one of them, fourth one, had a very small lesion in the breast, which was asymptomatic, and we got a biopsy done. We got a surgery that was only lumpectomy, just removal of this lump and radiation, and she's still alive. So this is now nearly 20 years. And that patient who was a mother, she died within 6 months. So that means it's same family, same disease. One was stage 4, which is no more within 6 months, and other was stage 1 asymptomatic, got diagnosed because of screening, and she is doing well. So you can see the spectrum of the disease and the spectrum of the results also. So the golden word here is the earlier the diagnosis, the best is the chance of cure.
Definitely, sir. It get diagnosed by chance. So you diagnosed one sister, and then it got diagnosed to the fourth sister. And since it was diagnosed at an early stage, it got treated, very soon, and there was less complexity. And she's now living a healthy, happy life. But this is what we want to target about the early detection and prevention. How it makes a big difference to your life, to your society, to the family, and everything. But despite all those things, there are big barriers which prevents women from undergoing regular screening like mammograms,
Hmm.
pap smear, or genetic testing. So how can we break these barriers, especially in the rural or underserved communities where we know that education level, awareness level is much lower as compared to any other tier 1 city?
See, this is a common problem. Even we see in the tier 1 city also. The problem here is the why they don't go for screening. First thing. Second thing is there any taboo attached to the malignancy? Second thing. So what I had seen is there is a lot of taboos attached to the cancer, and the second thing is there are a lot of myths. What I am telling is there is a huge myth cancer. If you do a biopsy of the cancer, if you do some type of tissue diagnosis, that means it is as good as doing a tissue को छेड़ने जैसा है, and that will increase the disease, that will increase to the spread of the disease. This is a very, very common problem, and this is seen in all type of people, irrespective of the socio-economic status. When we talk about screening, see, there are two types. One is scientific screening in the terms of mammography, but there are other things which is quite possible in the rural population, because everything cannot be implemented as per the guidelines which has been done by Western countries. You have a local problem, local solution has to be there. So when we talk in India, we see patients coming with the 8 centimeter, 10 centimeter fungating masses from the breast. So that means it has not jumped to this type of disease. There might be some gradual increase in the size. So what we say is ki every month, at least you do self breast examination. It is quite possible. It is easy. Patients herself can do this. There doesn't require any expert for that. And if she does a self breast examination of the breast, and if she sees something abnormal in the form of some lump or some abnormal swelling, or there is a discharge from the nipple, or there is a retraction of the nipple on the inner side, or there is some lymph node or lump in the axillary region, this is a danger sign. So if she is doing daily, regularly, every month, she will realize, oh yes, this was not there last month, and why I'm getting this lump this time. So at least if that is a lump is about, suppose it is 2 centimeters, still is curable. Suppose it's 3 centimeters, still is curable. So at least we can do this type of local screening in the form of cell-based examination. Second is clinical-based examination. This is to be done by doctors, which I feel it is very difficult because I have never seen any clinical-based examination to be done in a mass population. And third is mammography. Mammography is a very, very good test where we can screen the asymptomatic patient, not symptomatic patient. I am talking about the patient whom there is no palpable lump. The best example I can give with the clinical correlate is Martina Navratilova. She was a Wimbledon champion, I think 4 or 5 times Wimbledon champion. She, on the routine breast mammography, she had a very small lump which she got operated, and she's doing fantastically still now. But the reason being was she had an asymptomatic lump which was diagnosed by screening, and that's why she is doing well. Had this been a disease which was kept neglected and had she had the spread, the disease might, the impact and the result might have been very different.
Definitely, so that is what we are stressing upon. It would have been diagnosed at a later stage, or it also depends upon the person to person symptoms and the case they are going through. It becomes very difficult to treat at a later stage for the doctors as well, because there's a lot of complexities involved. And like the example you quoted with us, that how there were four sisters, one diagnosed at a later stage, one diagnosed at an earlier stage. So we with this we get to know that this role of family history also in determining the cancer
Mhm.
risk. So how can this genetic testing help in this proactive healthcare approach of getting tested early, and how it can help us to treat at the right point of time?
See, when we talk about breast cancer, there is a other second myth is it's a familial disease. So if there is one case in the family, that means there is a possibility कि सबको होएगा. Or if I don't have anybody in my family, that means I'm not supposed to get this. I'm immune to the disease. No, the answer here is only approximately 10% of the breast cancers are hereditary, that is familial, and nearly 90% are those breast cancers which don't have any family history. So the what is the family history important? If there is a two or more first degree relative with the breast cancer, or two relatives with one of the breast cancer, one in the ovarian cancer, or one of the male breast cancer patient in the family, these are the patients who are high risk, and in those patients we need to get a genetic counseling done. And generally people will correlate with the BRCA mutation, because BRCA is a very common test which is into the limelight because of Angelina Jolie. She did that BRCA testing and she was BRCA1 positive. Though she did had a cancer, she went with the prophylactic. That means she removed her breast, though there was no disease. And because in BRCA1 positivity, the risk of breast cancer is approximately 85%, and BRCA2, the risk of ovarian cancer is nearly 65%. So this is one example, but there are n number of genetic markers, which are genetic mutations, which are there, which can give us idea whether this particular individual is risk having any risk of getting a which type of cancer, either breast cancer or ovarian cancer or maybe pancreatic cancer. There are other tests which are coming up for the different types of cancer. So genetic counseling is very important in the patients who have got a strong family history of breast cancer.
So, since we're talking about how this genetic testing is there to help us in BRCA1 and BRCA2, it helped, it came in limelight because of Angelina Jolie. And I think this is all possible because of the advancements in, technological upgradation our healthcare sector got because of the day and night going researches, clinical trials, and everyone
Yes.
who's working day and night to make each and everything possible. So, since we're talking about these advancements, what do you think are some of the most promising breakthroughs in breast cancer, cervical cancer, or ovarian cancer treatments we have today?
Wow, very good question. So, of late, yesterday I went across an article which said nearly 160 new drugs were approved in oncology, which were highest in any of the field in medicine in world. So that means this is such a huge evolving field. There is a huge research. Approximately more than 2,000 clinical trials are undergoing in oncology, which is highest, and it is combination of all top five different types of diseases or types of specialty, and we combine. Then also it is less than the number of trials which are going on in oncology. So that means there is a huge advances. The advances are and the technological advances are huge because it is needed here. Because in last 50 years, you can see the number of deaths which are decreased from the CNS diseases, diabetes, heart diseases have dramatically come down. But the number of deaths in last 50 years because of cancer has not that dramatically come down as compared to this heart and cardiac and neurovascular diseases. So why? Because at certain level we had plateaued on the responses and the cure, so we needed a better weapons for this. So initially it was some surgery, then came the radiation therapy, then came the chemotherapy. Then they realized, yeah, chemotherapy के ऊपर भी कुछ होना चाहिए, so that कि they should target the cancer cells and not to target the normal cells, so that they can decrease the side effects, but at the same time increase the cancer killing cells, cancer killing potential. Then came the target therapy. The best example of target therapy in breast cancer is trastuzumab, that is Herceptin. This was a the landmark discovery of cancer treatment, and it changed the paradigm of breast cancer treatment. So it targets the HER2 positive cells, which are very very fast growing cells, but this has changed with the invent of trastuzumab, and this specifically kills those cells which are HER2 positive, thereby killing the lot of cancer cells and preventing the deaths of the normal cells and increasing the cure rates. So the in last 30-20 years, it has dramatically changed the spectrum of the treatment, spectrum of the disease, and we are seeing huge population of HER2 positive patients living. But having said this, it was just one example. Now we have got 4 or 5 different classes of drug in the same category. Then they realize that there might be some cells which are not positive for targets, and what we can do for those cells. Then came the advances of immunotherapy. Now we have got a huge role in cancer treatment in different lung cancer, breast cancer, cervical cancer, endometrial cancers, oral cancer, GI cancers, colonic cancers. So this is strongly coming into this. Again, one more thing which has come the day before yesterday, it was presented in SABC, where they had done was any disease which are less than 5 centimeters and single node positivity, they treated with the chemotherapy first, complete neoadjuvant chemotherapy, and if they on the pathologically they had a response by the biopsy proven or maybe PET scan negative, these patients were not subjected for surgery. This is one of the very big thing. That means you can avoid surgery in this type of patient who has got complete responses. So I think ये अभी तक कहीं पे भी न्यूज में पेपर में आया नहीं है, but once it comes it will be a huge impact, because any female, any person will try his her best, her organs can be preserved, and as far as possible, if surgery can be avoided, it's well and good for them. So this is the level of advances which we are seeing in the different types of cancer, and every day we are seeing new drugs, newer therapies, newer immunotherapies coming, which is helping us to treat the disease in a better way by decreasing the death rates and by increasing the survival without causing much of the side effects to the patient.
Definitely, rightly said, sir. Every day we are coming up with new technologies, new advancements to treat cancer patients in oncology. And like you quoted with the example that the number of amounts of drugs which is there, right? And I believe that is exactly need of the hour with the rising cases and everything. But since it is rising so rapidly, the
Hmm.
death rates have not come with the help of treatment options. They have also not come down because it's so high. But with this, we are like I said, we are focusing more on the prevention. So with AI and technology improving diagnostics, do you think we will soon have some home-based or non-invasive screening methods for women cancers,
Yes.
which will be easily available at their comfort of home, and the kind of discomfort or that I believe hitch is there to come out for in hospital for the screening, that will be sorted out with that.
Yes, I'm very strongly feel there will be this type of apps or maybe some screening method which will be by your touch screen method. By everybody has got data, everybody has got mobile, everybody has got a high-end mobile which has got 4G and 5G. So there will be some system where they can get a screening of your breast by using mobiles. this, I think this is just a matter of time. It is going to be there, and there will be some way where we can put a questionnaire with the data from the mobile, and which algorithms can be there, which can give us a risk of high risk, intermediate risk, low risk, and in those high risk, then they can go to a specialized doctor and get the screening done and get the investigation done, just to get assured whether they are suffering or not. Because in a country like India, which has got a huge population of 140 crores, with a females approximately some 50 crores, approximately we have got female population, and nearly approximately 25 crores in this age group where the breast cancer is a very highest. So it is impossible to screen those females, but at least this can be done. And if this is done based upon the technology, based upon the AI, I think we will get some good solution for early diagnosis, because the earlier is the diagnosis, the better is the cure. And the second thing is, if you can get at the home place, which as you have suggested, this will be very good, because there is impossible, it is really generally not possible for female to go to next city just to get a breast cancer screening done. Even in the same place, they don't get time to go because of the various problems, socio-economic problems, or maybe some familial issues, maybe some myths about the mammography. So I think this may help them.
Definitely so. So, since we're talking about how advancements in targeted technologies are helping us, so there's another buzzword is precision medicine in oncology. So, how do personalized medicine help tailor treatments to individual patients, and are these options accessible to average patients in India also?
Yes, a very good question, because now the treatment is very personalized. It's not that everybody will get the same type of treatment and one shoes fits all. This is
Yeah.
a old theory now. So what we do is, we every person has got a different genetics makeup, and every cancer cell has got a different genetic makeup. So, and this differ from the person to person, and in the same person may have tumor heterogeneity. So this is very tough question. So so when we target the disease, we have to be very sure what are the targets available in that particular tumor, because that is all is a precision medicine. So in precision medicine, what we are doing is, we are specifically targeting the cancer based upon the problem because of which the cancer arise, means type of mutation, or maybe some genetic defect, or maybe some markers. I had already explained, either it may be HER2 positive patients in the breast cancer, or triple negative cancer patients in the breast cancer. These are the predictive markers. Based upon this, we can target the disease if there is a possibility of positive HER2 or maybe triple negative malignancies. And this is, it's very important in selecting the correct drug, because the drug selection can be targeted based upon the correct diagnosis of the correct markers and genetic defects. Example I can say is in lung cancer. In lung cancer, initial treatment was only chemotherapy, but now we do the biopsy and we check for NGS, next generation sequencing. We say n number of markers: EGFR, ALK, ROS, PDL1, BRAF, and based upon this, if there is a EGFR positive, we have got at least 8 to 10 drugs to target that EGFR mutation. For ALK mutation, we have got at least 6 drugs to target that ALK mutation. For ROS positivity, we have got at least 3 to 4 drugs. So that means for every target, initially there was 1 or 2 targets. Now we have got a huge number of targets. Then for one target, there was initially was just 1 or 2 medication. Now we have got first generation, second generation, third generation. That means you can see we are dissecting the disease at the last root, so that we are understanding the exact genetic makeup of the disease, and we are targeting that problem per se, so that we can get a correct maybe maybe cure, or maybe a very sustained response in terms of control. So in diabetes, generally we don't talk about cure, but you have seen patients who are diabetic patient on insulin 40 years, 50 years, or with on tablets for nearly 30, 40 years. They are doing well. So that means they are living with disease with the good quality of the person himself. So that the same is concept now we are seeing in oncology, where we are controlling the disease, and we are making the disease so dormant that you can live with the disease with a good quality of life. Imatinib, which was a drug which was invented for CML, called chronic myeloid leukemia. Before that drug, the patient had no option but to go for bone marrow transplant. But a single pill had dramatically changed the disease treatment. Now, just a one tablet a day patient is fantastic. And if that person comes to your home or somewhere, you will never realize whether he is suffering from leukemia. So what has changed? It was just because they realized there was a defected BCR ABL gene. So this was the abnormal mutation which causes the proliferation of the cancer cells. And by just binding that ATP binding force site of the BCR ABL gene, this kills that mutation and that control the proliferation of the cells, and the patients have as good as normal life. So what I mean to say here is that we are understanding the disease in a better way at the genetic level, and thereby we can target that in a very precision way. This is called precision oncology, and slowly the oncology is moving towards from a higher toxicity to lesser toxicity, more lethal drug to the less lethal drug, injectable drugs to the oral drugs, admission to the non-admissions, surgery to the less surgeries, from less surgery to the no surgeries. So this is a very newer concept, from less surgery to no surgery. And these two concepts we can see here, there is a strong evidence. One is in rectal cancer, and second now it has emerged in the breast cancer. So slowly we'll see this, because we are seeing better drugs we can give complete cure or complete responses. So there is a complete response of the disease, and the disease has been completely cured. Then the next question arises, why there is need of surgery. So
Yeah.
now there are a lot of trials which are trying to address this question in a very scientific way. And if they succeed, and if they prove that surgery and no surgery, the life is same, then there is no point in doing that.
Thank you so much, Dr. Sushil, for explaining us that complex topic in a very simple manner. As it is very important to understand the treatment process as well as much as it is necessary to understand the screening methods, because then only patient or the listener would have the faith, how much upgradation, technological advancements have been made in our healthcare sector, that even if it has been diagnosed, we have better treatment options. With the complexities which are coming up, that is the need of the hour, and I believe India is successful to have all those things. Thank you for explaining and elaborating on that. But as we are moving close to end of our discussion, lastly, I would like to have your message that since it's an ongoing series for International Women's Day, what advice would you give to women today to take charge of their cancer risk and overall health?
See, there is a very simple thing, because lives in this current era, we have become very complicated, and we have ourselves have done that complication. So keep it very simple. Whatever our great grandfathers and grandmothers did, that was right. They used to get up early. They used to drink huge amount of water. They had a food pattern. They never used to eat after 6 or 7 o'clock. Then they used to eat fresh. There was hardly any chemical. There hardly there any pesticide. There was hardly any adulteration. Can you have you imagine? We see milk with urea, a lot of pesticides in the fruits. Fruits are being artificially ripened. So these are nothing but these are all carcinogens, and there is a tremendous pollution which we see. So what I'm going to say to all the everybody, not even females but also males, at least once a year we should have a regular checkup of ourselves. For female, at least if she is more than 40 years, if there is no family history, do mammography at least 2 to 3 years, at least once in 2 to 3 years. Pap smear at least once, and then every 5 years at least. And if there is a abnormal pap smear, so you can combine pap smear along with the EBV virus, HPV virus kit detection. And for even along with the screening, there is a for young girls who are less than 22, generally or before the sexual intercourse, at least they should have a human papilloma virus vaccination, which is commonly called cervical cancer vaccine, but it is a HPV vaccine. But it gives a lot of protection in terms of cervical cancer protection, vaginal cancer protection, vulval cancer protection, anal cancer protection, and oral cancer protection, along with the protection from the genital warts. So there, it has got a tremendous benefits. So for young girls in our family, young children, females, more than 12 years, but less than 15 years, they need 2 vaccination doses. And if they're between 15 to 22, they need 3 vaccination doses. Post marriage, there is the impact and the protection level goes down, but still it's not that zero. the biggest impact route is before we get go into the sexual intercourse or before they get married. So this is for Indian scenario. And at the same time, uh, uh, when we talk about prevention screening, again we can have a healthy lifestyle in terms of hydration, regular exercise, avoiding obesity, avoiding tobacco, avoiding alcohol, because again these are the factors which increases the risk of the malignancy in the normal people also. So if we have a good lifestyle, better sleep, along with the avoidance of these toxins and regular screening, I think this will decrease a lot of your risk of the cancer. And at the same time, if there is, unfortunately, if there is a disease, then at least we can have a chance to get a cure because of early diagnosis if you are getting a regular screening done.
Definitely right, sir. And that's why we with this session aims to emphasize more towards prevention rather than treatment. And we want this generation to come up strong, to be more focused on screening methods rather than, paying thousands and lakhs of bill of the treatment. Just pay 1,000 rupees or something for your screening methods. So thank you so much for encouraging our audience, our females out there, and other listeners also apart from females, for encouraging them, motivating them to take charge of their health, to be more focused towards prevention rather than the treatment, as if get it diagnosed on time, the treatment complexities could be reduced, or you may not have anything. That's the best. So thank you so much, sir, for sharing your valuable insights and expertise with us. It matters a lot as you have given your time for this important topic of for our society. Thank you so much, sir.
Thank you. Thank you. Good day.